Hello and welcome. My name is Jennifer Cinco, and I'm one of the directors of the National HPV Vaccination Roundtable. I am very pleased to welcome you to today's webinar, hosted by both the HPV Vaccination Roundtable and the American Cancer Society, featuring Dr. Giuliano, founding director of the Center for Infection Research in Cancer at the Moffitt Cancer Center. We scheduled today's talk specifically to closely coincide with the first ever International HPV Awareness Day, which took place on March 4th and will be an annual touchpoint of HPV awareness and educational activities. Before we begin, I want to let you know that this webinar is being recorded and will be made available on the HPV Roundtable website. Please type your questions in the Q&A chat box. We will have time at the end of the presentation to address questions or comments from the audience. I would now like to introduce today's speaker. Dr. Giuliano is the founding director of the Center for Infection Research in Cancer at the Moffitt Cancer Center in Tampa, Florida. She received her doctorate from Tufts University in Boston and continued her studies at the New England Epidemiology Institute in Boston and at the University of Arizona in Tucson as a National Cancer Prevention and Etiology Fellow. And from 1993 to 1998, she was the recipient of an NIH National Cancer Institute Prevention Oncology Career Development Award. Dr. Giuliano's career had its inception in the relationship between human papillomavirus, or HPV, infections and cervical cancer in women, and has evolved over the past 27 years to encompass HPV and penile, anal, and oral cancers in men, as well as other infectious diseases and their causal relationships with various cancers. Her work has contributed significantly to our understanding of the rate at which HPV infections are acquired and cleared, the proportion that progress to disease, and the HPV vaccine protection against multiple diseases in women and men. An expert in the field of cancer research with a long-standing and successful record of National Institutes of Health funding since 1990, she has been actively involved in cancer epidemiology and prevention studies conducted among diverse populations in the United States and abroad. In the course of those endeavors, Dr. Giuliano was a contributor to the 1999 Institute of Medicine report titled The Unequal Burden of Cancer, and the 2005 International Agency for Research on Cancer report that concluded for the first time that HPV is a cause of multiple cancers in women and men. In 2013, at the 100th anniversary of the American Cancer Society, she was also the recipient of the ACS Distinguished Achievement in Cancer Award. I had the great opportunity to meet with Dr. Giuliano when she gave this talk at the American Cancer Society on January 9th, and I know you are in for a moving and inspirational hour. With that, I turn the virtual floor over to Dr. Giuliano.
Thank you so much for that wonderful introduction, and it was indeed a really wonderful visit with all of you at the American Cancer Society on January 9th. In speaking to you and others in the community, I think I'm speaking to the choir. All of us for many years now have been involved in really trying to promote HPV vaccination as well as screening for cervical cancer. And so much of what we've been doing is really about taking what we know and applying it and actually convincing other people to want to do the same thing. And I think now we're finally at that last point in the clause, which is now we must actually do. And I think what you'll see in today's presentation is that we're actually able to take, I think, a really giant leap forward in terms of what is our willingness and what is our ability and what we actually can accomplish. And what I'm hoping to do today is to move everybody from the concept of increasing HPV vaccination, which is a very necessary step, to the concept of actually eliminating HPV-related cancer, starting with cervical cancer. And I hope that after today's talk that I've inspired all of us to that mission and to the reality that this goal is within our lifetimes and within our reach. So when we say eliminate anything, you know, we've been pretty conservative. We've been talking about, oh, we want to control cervical cancer, we want people to increase screening, we want to maintain screening, we want to increase vaccination, and so on. But we've never, as a community, actually embraced the word elimination. And I think in part because, you know, we've all been so busy trying to make things happen on the ground. And there, you know, it's been a lot of work that we sort of never allowed ourselves to actually think that we could eliminate these cancers. And what I'm going to do now is just show you two examples of infections that cause disease. The first is viral hepatitis, and you can see here on the slide. Now, for those of you who are unaware about hepatocellular carcinoma, most of those liver cancers are caused by hepatitis B and hepatitis C. Now, you know we have a vaccine for hepatitis B, and we have screening and treatment for hepatitis C, but I can tell you, as someone who's working in that area, we are nowhere near where we are with human papillomavirus and the cancers that we can prevent with vaccination. And yet you see here that in June of 2016, the World Health Organization announced a global health sector strategy on viral hepatitis. And I want you to note something here: eliminating viral hepatitis as a major public health threat by 2030. We only have a vaccine for one of those hepatitis viruses, and that's Hep B. And yet WHO felt strongly enough that they had the evidence to make an elimination statement. Now, another example is the Getting to Zero campaign, which is the AIDS epidemic, UN AIDS program on ending the AIDS epidemic by 2030. And again, here we go. We have screening and we have treatment, but as most of you know, we do not have a vaccine. And in fact, the vaccine is a critical component to really accomplishing an elimination goal. And yet UNAIDS has made the statement that they plan on achieving a goal of ending the AIDS epidemic by 2030. So when we say elimination, what exactly do we mean by that? And let's kind of go through the checkbox and see whether we as a community in HPV and HPV-related cancers can make a similar statement. So I thought, well, let's start with the definition. So control. That's the reduction of disease incidence, prevalence, morbidity, and mortality to acceptable levels. And when I show you in a little bit the incidence of cervical cancer and what we have accomplished in the United States, I think you'll clearly see that we have controlled cervical cancer. So we're at that point. Well, what about elimination of disease and infection? What exactly does that mean? Well, here we're talking about reduction to zero or near zero incidence of the disease or the infection, and this is a clause that's critical, in a defined geographic area. And that's what really separates the word elimination from eradication. So for instance, we have eliminated polio from the Americas. We still vaccinate against polio, and polio, as many of you know, still exists in certain parts of the world. But in the Americas, so let's just take in the United States, we have eliminated polio. Eradication is the permanent reduction to zero worldwide of the incidence of infection caused by a specific agent. And here we really only have one example of eradication, and that's the eradication of smallpox, which we successfully accomplished and then no longer need to vaccinate against. But we're going to focus our attention on elimination of disease and elimination of infection, because that's what we think we can accomplish with the HPV story. So, all right, so elimination. Do HPV and cervical cancer satisfy the necessary preconditions for elimination? Well, we go back to our definitions here and say, okay, so is there an animal reservoir for the virus? And the answer is there are a lot of papillomaviruses that infect animals, but those are not human papillomaviruses. Human papillomaviruses only infect, there is no animal reservoir. These are only infecting humans. All right, do we have sensitive and specific tools available for the diagnosis and surveillance and treatment? Now here, let's talk about cervical cancer, because we're going to start with cervical cancer. And, you know, I think we all know the answer is yes. We have, and in fact, our tools are improving every year. We have the Pap smear, which even in its crudest form worked very well to drop the incidence of cervical cancer. And today, we have molecular tests that are far superior even to the old-fashioned cytology. So very much so, we have sensitive and specific tools for the diagnosis and surveillance of cervical cancer. So transmission from one individual to another can be interrupted. The answer is yes, and I'm going to show you some data from Australia which clearly showed that even with just a female-only vaccine program, they have observed a significant drop in genital warts in the males in Australia who were not vaccinated. And this effect, of course, is due to herd protection and breaking transmission from one partner to the other through vaccination. So number 4, non-lethal infection or vaccination confers lifelong immunity. Now you see that I put a question mark here. Non-lethal infection, that's, when people are infected and develop an immunity to natural infection, we really only see partial protection from the natural antibody that's produced. And our estimates from women, which have been the best studied, it's around 36% of all women who are infected with HPV will develop an antibody that actually provides protection. And vaccination, well, you all know this story. I mean, 100% seroconversion. And what we're really seeing now with the long-term follow-up of the participants in the vaccine trials, and even what we're seeing in the communities is that we're seeing very long-lasting duration of protection. I kept that question mark there because we haven't had 50 years of follow-up following vaccination. But all the evidence that we have to date would really suggest that we will see long-term and maybe even lifelong immunity following vaccination with the HPV vaccines. Number 5, the burden of disease is important to international public health. Certainly that's a correct statement. I don't think we would ever have seen such a community gathering together, doing the research that's been done, producing the vaccines, testing the vaccines, and really having the effort that we all have seen internationally if we didn't think that elimination of these cancers was important. And then finally, the political commitment to elimination efforts exist. I think we're really starting to see kernels of that political commitment. And I think to really galvanize a political commitment, we as a community need to stand strong and actually accept that we can eliminate these cancers and show the world that we can. And I think what we'll find is that we will increase the political commitment over time when we do that. So let's just kind of go through this. HPV, as you know, causes multiple cancers. I'm showing you the pyramid. It's designed as a worldwide pyramid, and you'll notice that I have not put numbers here. And part of why I haven't put numbers is that most countries in the world do not have good cancer incidence registries. So we're kind of guessing at the actual number of cases that occur. I mean, we're in a much better position here in the United States with counting cases. And we're really at the most recent count from the 2014 data, in the tens of thousands when we look at both males and females. But just to remind everybody, the cancers that HPV causes in men are penile cancer, oropharyngeal cancer, and anal cancer. And in females, it's vulvar and vaginal, oropharyngeal, anal, and cervical cancer. And in countries that screen, I mean, the really, really big burden are all of those cervical dysplasias. And not to diminish the importance of the non-cancers, and genital warts is important. And if you've ever spoken to a patient with genital warts, they make it very clear that this is a difficult disease for them. That actually forms one of the largest burdens of disease. Now, although HPV causes all of these cancers, we actually don't have screening for any of the cancers other than cervical cancer. So what we say is that we can eliminate cervical cancer first because we have two major approaches. We've got screening and we have vaccination. And for the other cancers, we're going to be dependent completely on vaccination, which means it's going to take us a little longer to get to that elimination. So just by way of review, the cancers and the diseases that HPV causes in males and females have different types of HPV. So for instance, when we look at the non-cancers, genital warts and recurrent respiratory papillomatosis, Over 90% are caused by HPV type 6 and 11. Cervical cancer is unique among all the cancers, where, we say that approximately 100% of those cancers are caused by HPV, and the overwhelming majority of the types of HPV that cause those cancers are type 16 and 18, with an additional 13 other HPV types. Vaginal, vulvar, anal, penile, or pharyngeal and oral cavity cancers are predominantly caused by HPV 16 and 18. So a much simpler story in terms of type diversity than cervical cancer, but a little more complicated in that not all of these tumors are caused by HPV. So anal cancer being the one that most resembles cervical at this point, with around 80 to 90% are due to HPV. Or pharyngeal in the United States, in our look here at the Moffitt Cancer Center, around 90% of those tumors today are caused by HPV. But this varies greatly by the tobacco use prevalence in the different countries and different communities. So the more we've had tobacco control policies and really reduced the prevalence of smoking, the higher the proportion of these tumors that are due to HPV. And again, I just want to remind everybody, other than cervical cancer, we do not have available reliable screening methods. Again, reinforcing the statement that vaccination is crucial to both the control and the elimination of the other non-cervical HPV-related cancers. When we look at the incidence of cervical cancer, we see that it varies greatly around the world. So here we are in the United States and Canada, and we're doing very well because we have had organized screening programs for decades now. And you can see for the countries, and usually in the low and middle resource countries, have not been able to effectively launch pap smear screening programs. You see that the incidence, the darker color, is quite high in sub-Saharan Africa, parts of Latin America, and in large part in Asia. Now, I'm going to focus on the good news story. I mean, we typically use this slide to say we need to get resources to the poorer countries, and that's true. But we also need to demonstrate that we can eliminate cervical cancer. And so it's important to highlight where we have had the success in controlling cervical cancer. And that, in large part, is the United States, Canada, and Australia. And these are the same countries that have also been implementing vaccine programs. So I want us to turn our attention to what's possible and what's positive, and to set the example for so many other countries of what's possible for them to achieve as well, should they embark on national vaccination programs and even very simple screening programs. So the prevention of cervical cancer really follows the line of primary prevention, secondary prevention, and tertiary. And we're going to focus primarily on the primary prevention, which is vaccination of girls and boys in the recommended age group. So we try to get to these adolescents before they turn 15 so we can, implement a simpler vaccine dosing schedule. It's important to know that catch-up vaccination is very much so part of our national program, 15 and older, but would require the 3 doses. The secondary prevention in most countries is implemented with screening at the age of 30 and older. In the U.S., we've always had our own recommendations that are slightly different. But the basic tenet here is that secondary prevention is about identifying the high-grade precancerous lesions, referring the woman appropriately for treatment, and reversing the cervix back to normal, and thereby preventing the cancer. The tertiary prevention is really, really about preventing death due to cervical cancer. And this is, of course, the earlier we can identify the invasive cancer, the better able we are to increase the lifespan and survival of that patient. So cervical cancer control, as I mentioned, really has been effectively accomplished here in the United States. We have screening, and we have treatment for the precancerous lesions. So what does that look like for us? Well, we have those sensitive and specific tools to identify the high-grade cervical intraepithelial neoplasias. We've had the Pap test for decades. You know, we've gone through several iterations of actually collecting the Pap, the material, and putting it directly on the slide, moving to the liquid cytology, and now actually moving to what most of us think is a preferred method, which is molecular testing with HPV DNA testing. And that can be co-testing, or it could be a primary HPV test, then followed by more of the cytologic and colposcopy methods. And even in the poorest countries, we have a method. It's not as wonderful as HPV DNA testing, but it is a method that can be utilized, and that's visual inspection with acetic acid, or sometimes what's called the screen and treat approach. And even for those very difficult to reach women in rural areas or those who are uncomfortable with the clinical procedures, there's been a lot of work showing that self-sampling methods hold promise for overcoming a lot of the cultural and access barriers that might exist for the diagnosis of these high-grade cervical lesions. We have effective methods to treat those high-grade precancerous lesions once they are detected. So you'll see there's surgical methods, as simple as a cold knife conization. Here in the United States, large loop excision procedures, as well as ablative therapies. So different therapies that can be adapted to different settings, whether it's a high resource or a low resource setting. And in fact, I think the United States is a wonderful example of how when you implement that screening and the treatment for the precancerous lesions, you effectively control the cancer. And so what we see here in African-American women who started with a very high incidence of the cancer, I'm showing you the years from 1975 to 2014, a wonderful, effective decline in the incidence of cervical cancer, regardless of race and ethnicity in this country. But one of the things you need to note, we've done very well. We have dropped from as high as in the 30s per 100,000 to around 6 to 8 per 100,000. We are in the position now by adding vaccination to get to 0. And that's the vision for the future, and that's the message that I think we all need to be sending out to really, really encourage people to see that end goal and why they should be vaccinating, why they should be continuing treatment, and why they should be continuing to get treated for the lesions, the precancerous lesions that are detected. Very similar to the drop in incidence, you see a significant drop in mortality. Now, of course, if we didn't have any cervical cancers, we would have 0 mortality. And again, that is the end game. All right, well, what would that look like? Cervical cancer elimination is akin to a 3-legged stool. Vaccination plus the screening and treatment that we've already been doing in the United States. Well, what's the evidence that vaccination would really accomplish that goal? Well, you know, amazingly, looking at the data coming from effectiveness studies, these are post-vaccine trials where vaccine is now given to women in several different countries around the world. Without doubt, the effectiveness of the vaccine has actually far exceeded our expectations when we saw the clinical trial data. And in large part because we are able to get community herd protection, which is much greater. The larger the number of people in a community vaccinated, the greater the protection overall for that population beyond what is accomplished at the individual level. Okay, but what have the trials told us? Well, nearly 100% efficacy against the 7 cancer-causing or oncogenic HPV types that Gardasil 9 is directed against, without doubt. And the safety data are continually monitored. Without doubt, this is a very safe vaccine. We've seen delivery of the vaccine to over 30 million people around the world. There has been enduring protection, as I mentioned earlier. And since 2013, there have been heavily subsidized vaccine purchasing, allowing countries at all different levels in the economic spectrum to be able to purchase. A wonderful example is the Gavi program, which provides vaccine at a very low cost to the poorest countries in the world. And in the Pan-American Health Organization region, PAHO has negotiated a revolving fund price that really has enabled almost all countries in Latin America to purchase vaccine and start national vaccination programs. We've been able to see that the vaccine can be distributed whether it's a high-resource country or a low-resource country. And in fact, we've seen that greater than 70% of the low and middle-income countries, as well as the high-resource countries, have been successful. Some good examples are the countries of Bhutan, countries of Rwanda. So even, in fact, the country of Rwanda has been incredibly successful, one of the low-resource countries in sub-Saharan Africa. So we know we can deliver vaccine. That is not the question. So what is the evidence that vaccination interrupts transmission? So I had alluded to the Australia story. In 2007, Australia launched a national female-only Gardasil vaccine trial program, a national Gardasil vaccine dissemination program. And it was for females only. But what they observed when they followed heterosexual males is a significant drop in the incidence of genital warts, which they attribute to herd protection. And you can see the protection was among the aged eligible men who are likely interacting with the girls who were vaccinated, whereas the men who are over 30 who were likely not interacting with the females that were vaccinated, we saw no protection. But the bottom line here is that we can interrupt transmission with vaccination, satisfying one of the important elements of defining the criteria for elimination. HPV vaccination, once delivered in national programs, has reduced the incidence of genital HPV infection, genital warts, and high-grade cervical intraepithelial neoplasia. What I've listed here are a series of countries that have published reports demonstrating this. Australia, Denmark, the Netherlands, Scotland, Sweden, even the United States, where, you know, we always cry that we haven't reached enough women, and it's true, we haven't reached enough boys and girls for vaccination. But even with our lower vaccine uptake rates, we've been able to demonstrate significant reduction in each of these important endpoints. There have been meta-analyses, and what these are studies where they actually collect the data from multiple countries. You can see the flags of the different countries that were represented, and ask the question, what is the effectiveness of the vaccine? So is this limited to certain countries? And what is the overall effect when we combine the experience across all those countries? So the bottom line here is really what's in the title, a 72% lower infection with HPV 16 and 18 following vaccination of girls in the target age group, girls ages 13 to 19. Now this is the relative risk for the infection, and what you can see very nicely is that if it's a low coverage of vaccine, you're not going to get as much reduction. But if it's a high coverage, you can see the relative risk is around 0.3, which means around a 70% reduction. So the higher the coverage, the greater the reduction in the infection across all of these countries. Even in the United States, and these are data now looking at the vaccine era, the very early years, 2007 to 2010, and as many of you recall, we were really struggling to get vaccine out there in those years. So this study compared the relatively low vaccine uptake period of time to the era prior to vaccination. And even with that lower vaccine uptake, we showed significant reductions, 56% reduction in the prevalence of the 4 vaccine types and a 50% of the types that we know to cause cancer. But probably what's most exciting is when you start seeing zeros in these columns. And these are data now coming from Finland. It's the first report to actually provide data on the incidence of the cancer, the cervical cancer, vulvar cancer, oropharyngeal, and other HPV-related cancers. What this group of investigators did was to take the women who were in the clinical trials in Finland, who were vaccinated, and compare them to women who were not vaccinated in Finland, who are of the same age, living in the same geographic region. And what I'd love to show here is the number of cases of these cancers in the vaccinated group. And I don't have to say much here, they're all zeros. Compared to the non-vaccinated group where you see numbers, 8 cervical cancers, 1 vulvar, and so on. This is the first evidence that the vaccine indeed will lead to a count of 0 for the cancers that HPV causes. It's very, very exciting. I think in the next few years, with the Nordic countries having such amazing vaccine registries and cancer registries, my hunch is we are going to continue to see additional publications essentially replicating the zeros in these columns. Now, those were data looking at the effectiveness of Gardasil. That was the first vaccine against the 4 types. But now, especially here in the United States, we have been implementing the 9-valent vaccine. So now we will have an additional 20% reduction with this vaccine against cervical cancer, an additional reduction against the high-grade cervical intraepithelial neoplasias that HPVs cause. So the future, I think, looks incredibly bright. But what about those countries that I mentioned, you know, the map where there really hasn't been effective cervical cancer screening? And what about those cancers that we don't have screening? This is where vaccination is our primary tool. Now, it may take us longer to reach elimination in those settings against cervical cancer and as well as against the cancers other than cervical cancer. But it is possible. These are cancers caused mainly by HPV-16. What do the models tell us? This is a collaboration of multiple mathematical models across different countries and ask the question, how long will it take to eliminate HPV-16 when we do a girl-only vaccination program or a gender-neutral? I really want to focus you on HPV-16 because this is the virus that is hardest to get rid of. And you can see it takes us the longest. For HPV-6, we drop relatively quickly, the same with 18 and the same with 11. But 16 is the harder one to eliminate, and it also happens to be the one that causes the majority of the cancers that HPV causes. And so from this visual, it would be 40 years to elimination with a vaccine program only if it were gender neutral. And it would be 70 years if it's a girl-only program. So the model tells us this. If we can achieve 80% coverage of both girls and boys, it would be 40 years to the elimination of HPV-16. Now, we're not talking about the addition of screening. This is vaccination alone. So I just want to make that clear. What I haven't seen yet, and this is something that several modeling groups are working on, is in the setting like the United States where we've achieved control with pap smears, and you add vaccination, how many years will it take to eliminate? And I think that's going to be a lot less than 40. So this is vaccine only. Now, it would take 70 years with a girls-only program of vaccination sustained at 100% coverage. So it's clear that if we are to eliminate all of the HPV-related cancers, it is essential that we have gender-neutral vaccination and that we maintain high coverage. The other is that I showed you the slide from Australia of a break in transmission among heterosexual couples. But what I didn't show you is that among men who have sex with men, there was no benefit to them of a female-only program. So to really complete elimination, it is essential that it is a gender-neutral program. Not only from the modeling perspective, but from the practical perspective. So many countries have had interruptions in the vaccine delivery program. I mean, we've seen this now with France, with Denmark, Japan. We really think that a gender-neutral vaccine program adds resiliency to the fluctuations in the vaccine coverage over time, because we're reaching a higher number of total people in the community. So we add a resiliency to any interruptions that may occur. Well, where are we worldwide? 2007 was probably the first full year of vaccine availability, and you can see the US and Canada and Australia and parts of Europe came on early. We are seeing a wonderful increase. Here's 2010, 2013, and here is now October 2016 with over 100 countries that have initiated some level of either a national program or a demonstration program, and the number is even higher now. So the world is catching up to us. We're really starting to see that momentum worldwide of vaccine distribution. But there's a lot left to be done. We know here in the United States, we have not achieved our 80% vaccination goal. I believe very strongly with the efforts of the American Cancer Society and others around the country that we will achieve that, and we will achieve it by 2026, if not sooner. I would like to see us exceed the goal. But around the world, here's a population of women who, total female population, and you can see in blue the number that are targeted for vaccination, and in pink, the proportion that actually has received it. So worldwide, we have a lot of work to be done. And I think as a community, if we can galvanize the political will and really show the potential to eliminate so many of these cancers, that we will see this pink get bigger and bigger and bigger. So what about that political will? There are kernels of political will, no doubt. The World Health Organization has global action plans, several of them, that actually mention cervical cancer. Clearly, the Pan American Health Organization negotiating a low price with a revolving fund for vaccine is committed. We have several international and national non-governmental organizations that have come online, donors, the Union for the International Cancer Control, FIGO, the First Ladies Initiative, the pink ribbon, red ribbon, as well as several individual countries. Canada, for instance, plans on making an elimination statement as part of a feminist agenda for their country under the new president. The United States Global Cervical Cancer Program published in November 2016 this statement, "The End of Cervical Cancer, Prevent, Treat, and Care," and the participating agencies are listed below, and you can see there are numerous agencies. We now need to move each of these agencies to the next step, which is garnering the resources and developing the action plan. So if we think of it broadly, we think of three strategic directions to accelerate elimination of HPV-related cancers. That is to advance human rights and gender equity for HPV-related cancer prevention, catalyze a new generation of screening and treatment, really make it available in the poorest countries under any conditions, and revolutionize HPV prevention. Develop methods to disseminate that vaccine effectively and to maintain the dissemination over time. The goals, I've come up with a 90-90, and it really is borrowed from the Getting to Zero campaign for HIV. These goals will have to be set by individual countries. It's just a placeholder right now, but at least 80% for each of these. I like to set goals that are more ambitious to really drive the agenda. Here we have 90% vaccinated, gender neutral, 90% screened for cervical cancer, and 90% treated for cervical disease. What's the vision? So vision of a world without HPV-related diseases. We start, I think, if we can accomplish our goal, eliminate cervical cancer as early as 2030 in some geographic regions. Remember, elimination is within a geographic region. Can the United States be the first country? Maybe, if we're successful in all of our endeavors. And then eliminate HPV-16 altogether by 2060, which would mean the end of the majority of HPV-related cancers in both males and females. So we need to start today. I want to remind everybody that one woman dies every 2 minutes. We need to coalesce all the global players. Communication is central to that. An amazing starting point has been the work of the American Cancer Society with the HPV Roundtable. We need to grow that. We need to grow it worldwide. We need to set a clear goal for cervical cancer elimination, set a date. I think 2030 may be possible. This needs to be evaluated in different communities. We need to develop a global leadership team, and we like to use the word the network of champions. We're all champions in each of the different areas, and we each contribute to this mission in different ways. And it's really about coalescing that team of champions to accomplish the goal. We need to develop an action plan and milestones and ensure that there's gender equity and justice in the availability of the interventions to accomplish that goal. And then we have to get countries and municipalities to implement the plan and monitor the annual progress globally in achieving the plan. We have the tools to eliminate cervical cancer. We need to advocate for elimination. Advocating for elimination will increase awareness and galvanize that political will. We should endorse and embark on a cervical cancer elimination strategy with enthusiasm and without delay. And I have to tell you, so many of those words are from my friend and colleague, Mark Cade, who worked on the hepatitis B vaccine campaign. And you know, in this country, we vaccinate very effectively, and we've seen a significant reduction and almost elimination of liver cancer that's caused by hepatitis B. So we think really we can accomplish very similar goals with HPV. And we really, as a community, believe that the end of cervical cancer is in sight. And with that, I want to thank you all for participating in this webinar.
Dr. Giuliano, thank you so much. Even having heard this talk before, I get this bubbling sense of excitement inside of me when I just think about the potential for the elimination of this cancer, of cervical cancer and other HPV cancers. We did have some questions come in through the Q&A chat box, and if anyone on the line is still interested in asking some questions, I encourage you to write them in the box. But one of an early question we had was about the HPV test and what strains of HPV the HPV test check for.
Right. So the current test tests for all of the types that cause cervical cancer, and the panel is divided into testing for 16 and 18 separately from the other high-risk types. And the procedure for triage to follow-up is really dependent on the type that the woman is positive for. But the test is able to test for all of the cancer-causing types.
Great. And then you had a slide that was a pyramid, and it showed sort of HPV-caused or HPV-related diseases. And someone asked if ocular cancer was going to be added to the list. And curious if you know anything about ocular cancer being added to the list?
You know, so that's a really good question. How most of us build the pyramids that I've shown, it's really from the statements that the World Health Organization has made in terms of which cancers HPV causes. And so just to give a little history before answering that question directly, in 1995, there was only sufficient evidence in the published literature to make the causal statement that HPV-16 causes cervical cancer. Now, there had been some papers showing associations between other HPV types in cervical cancer and HPV-16 and other cancers. But it wasn't until 2005 that scientific evidence had grown to the point where there was sufficient evidence to make a causal statement about HPV and the cancers that I listed in the pyramid. Now, the research continues, and there are people who are really interested in understanding whether HPV causes cancer at other sites, and you know, ocular would be maybe one of those sites. But today, we don't have sufficient evidence to make that statement. And so I've restricted the pyramid to only the cancers and the diseases for which we have a causal evidence for HPV and that disease.
Thank you. A couple of people asked specific questions about the Finland data. You had a slide that showed two columns. One column on the left for women who had been vaccinated, column on the right, women who had not been vaccinated. And there seems to be almost a protective effect for other cancers, not just HPV-related cancers, in the women, in the HPV-vaccinated women. Could you explain what some of the potential factors are leading to the differences in other cancer rates between these two groups?
Right. I would not make a statement about that. One of the things that we have to look at is, and I don't know if you can still see the slide, I'm pointing to the confidence interval, which is very broad. And if you look at the confidence interval, they're very similar for both groups. The point estimate is housed somewhere in here. So I'm not sure it is appropriate to say that the incidence is lower for these other cancers in the vaccinated group versus the non. I would be very cautious in interpreting the data that way.
Okay. Thank you for the clarification. We just had a question come in that I'll read directly. It says, you had mentioned that there is support for eliminating cervical cancer at a high level. Is this a priority at a national political level? I work in the South, and there are significant challenges with even talking about HPV and the vaccine. And you're based in Tampa, so I'm sure you are really aware of the political challenges.
I am very aware of it, absolutely. And I think, you know, this is why I think if we build an agenda around elimination of the cancer, that will actually help our cause to increase the vaccination rates and to maintain the screening rates. If the message is always just vaccination, I think we end up getting caught in the muck and mire of the politics and, you know, a lot of the false statements that are being made on Facebook and in social media. And that's why I think at a national level, we need to convince the NCI director and people very high up at CDC that elimination really is possible and that that's our end game. And then what are the steps to accomplishing it? We work on those steps, but we focus our attention and the attention of the public on elimination. We are making progress. We are taking steps to get to the point where, and I'm hoping, and we're not there yet, where we have the people at the very highest levels in Health and Human Services at the NCI, NIH, and CDC also making this elimination statement. This is a process. I think you're going to see American Cancer Society is coming out early The International Papillomavirus Society has come out early. We've made a policy statement that is on our website, our society website, and we've published it now in our society journal, which is Papillomavirus Research. So step by step, I'm confident that we will have this political support at the highest level. We just have to make it happen and make it happen as soon as possible.
Thank you. So we have about 5 minutes left, and I'm not seeing any additional questions. Oh, actually there is one. So Dr. Giuliano, someone asked if the slides would be available. We are going to make the recording available, so it will be your slides coupled with the audio, but this is a question specifically about the slides themselves.
Yeah, and I see, I am peeking at some of the questions. If it's coming from the Centers for Disease Control and Prevention, I will be doing a very similar webinar with CDC on March 26th, I think it is, and let me just check my calendar. So at that, I mean, I would, for anyone who is from CDC, I would strongly recommend that they contact Lori Markowitz and join that teleconference. If it's people outside of CDC, then yes, I mean, I'm happy to share these slides.
Thank you. Well, that seems to be all of the written questions. Dr. Giuliano, thank you so much for joining us today. This talk really is, I think, so important to hear for those of us who are doing this work day in, day out, that we could be part of a movement in our lifetimes to eliminate a cancer, and not just any cancer, but cervical cancer, which has both a domestic and a global burden that is quite onerous. So thank you again for today. If there are any questions, follow-up questions, please feel free to reach out to me, Jennifer Cinco. My contact information, I will put it in the Q&A box, and I will be happy to triage to the appropriate experts. I want to thank Debbie Soslow and the American Cancer Society for co-hosting along with the HPV Vaccination Roundtable, and to the support staff that made this event possible. And with that, I will close and give you back 3 minutes of your day, and I hope you use that time to tell someone that we can eliminate HPV cancer, starting with cervical cancer, with the tools that we have right now. So enjoy your day, and goodbye.